Hi, my name is Dr. Hussein Hadi from the Department of Pathology and Forensic Medicine at Mustansariya University. This presentation is the last talk of a series lectures that would outline the endocrine system from the pathological point of view. At the end of last lecture, I gave an overview for adrenal cortex and its main disorders, and I started to discuss the adrenocortical hyperfunction in more details, including the Cushing syndrome that is characterized by an excess of cortisol. Today, I will try to cover the other adrenocortical hyperfunction disorders, including the hyperaldosteronism, as well as the adrenogenital or virilizing syndromes. Then after, I will discuss the adrenal insufficiency, and hopefully at the end of lecture, I will talk about the neoplasm of adrenal medulla and the multiple endocrine neoplasia syndromes. To begin with, I will discuss the hyperaldosteronism. Hyperaldosteronism is the term for a group of closely related conditions characterized by chronic excess aldosterone secretion. It may be primary or may be secondary to an extra-adrenal cause. Primary hyperaldosteronism refers to autonomous overproduction of aldosterone with resultant suppression of the renin-angiotensin system and decreased plasma renin activity. This table illustrates the causes of primary hyperaldosteronism, and these are bilateral idiopathic hyperaldosteronism, adrenocortical neoplasm, as well as familial hyperaldosteronism. For the bilateral idiopathic hyperaldosteronism, it is characterized by bilateral nodular hyperplasia of the adrenal glands. It accounts for about 60% of cases. The pathogenesis is unclear, although a subset harbors germline mutations in the KCNJ5 gene, which stands for potassium inwardly rectifying channel, subfamily J member 5. The adrenocortical neoplasm, either an adrenocortical carcinoma, which is a rare cause, or most commonly aldosterone-producing adenoma, a condition referred to as Cushing syndrome. We should know that the somatic mutation of KCNJ5 are also present in an aldosterone-secreting adenomas. Rarely, familial hyperaldosteronism may result from a genetic defect that leads to overactivity of the aldosterone synthase gene, which is the cytochrome P450 family 11 subfamily B member 2. This figure demonstrates the major causes of primary hyperaldosteronism, most commonly the idiopathic hyperaldosteronism as well as the adenoma. Chronic excess of the aldosterone secretion can result in potassium moves from bloodstream into tubule and is excreted. In addition, the sodium is reabsorbed from tubular urine back into the bloodstream and may cause the hypertension. In secondary hyperaldosteronism, aldosterone release occurs in response to activation of the renin-angiotensin system, characterized by increased levels of plasma renin, and is encountered in association with the following, as seen in this table. First, decreased renin perfusion, including arteriolar nephrosclerosis and renal artery stenosis. Secondly is the arterial hypovolemia and edema, such as the congestive heart failure, cirrhosis, and nephrotic syndrome. Pregnancy could also be associated and is caused by estrogen-induced increases in plasma renin substrate. For the morphology, the aldosterone-producing adenomas are almost always solitary, small, less than 2 cm in diameter, and well-circumscribed lesions. They are bright yellow on cut section and are composed of lipid-laden cortical cells more closely resembling fasciculated cells than glomerulosa cell, which is the normal source of aldosterone. In general, the cells tend to be uniform in size and shape. Occasionally, there is some nuclear and cellular pleomorphism. A characteristic feature is the presence of eosinophilic laminated cytoplasmic inclusions known as spironolactone bodies. These typically are found after treatment with the antihypertensive agent spironolactone, which is the drug of choice in primary hyperaldosteronism. In contrast with cortical adenomas associated with Cushing syndrome, they do not usually suppress ACTH secretion. Therefore, adjacent adrenal cortex and that of the contralateral gland are not atrophic. Bilateral idiopathic hyperplasia is marked by diffuse or focal hyperplasia of cells resembling those of the normal zona glomerulosa. In hyperaldosteronism, we should know that the most important clinical consequence is hypertension, with a prevalence rate of 5 to 10% among unselected hypertensive patients. Primary hyperaldosteronism may be the most common cause of secondary hypertension. In addition, hypokalemia results from renal potassium wasting and, when present, can cause a variety of neuromuscular manifestations such as weakness, paresthesia, visual disturbances, and frank tetany. In primary hyperaldosteronism, adenomas are amenable to surgical resection. By contrast, surgical intervention is not very beneficial in patients with primary hyperaldosteronism due to bilateral hyperplasia. These patients are best managed medically with an aldosterone antagonist called the spironolactone. Treatment of secondary hyperaldosteronism rests on correcting the underlying cause of the renin-angiotensin system hyperstimulation. The other adrenocortical hyperfunction is called adrenogenital syndromes. They refer to a group of disorders caused by androgen excess, which may stem from primary gonadal disorders and several primary adrenal disorders. The adrenal cortex secretes two compounds, namely dihydroepiandrosterone and androstenedione, as seen in this arrow, which require conversion to testosterone in peripheral tissues for their androgenic effects. Adrenal androgen formation is regulated by ACTH. Thus, excessive secretion can present as an isolated syndrome or in combination with features of Cushing disease. The adrenal causes of androgen excess include adrenocortical neoplasms and an uncommon group of disorders designated as congenital adrenal hyperplasia. So first, the adrenocortical neoplasms is associated with the symptoms of androgen excess, which is the virilization, and are more likely to be carcinomas than adenomas. In regard of congenital adrenal hyperplasia, it represents a group of autosomal recessive disorders, each characterized by a hereditary defect in an enzyme involved in adrenal steroid biosynthesis, particularly cortisol. In these conditions, decreased cortisol production results in compensatory increase in ACTH secretion due to absence of feedback inhibition. The most common enzymatic defect in congenital adrenal hyperplasia is 21-hydroxylase deficiency, which accounts for greater than 90% of cases. In the adrenal glands, cortisol, aldosterone, and sex steroids are synthesized from cholesterol through various intermediates. 21-hydroxylase is required for synthesis of cortisol and aldosterone, but not sex steroids. Thus, deficiency of this enzyme reduces cortisol and aldosterone synthesis and shunts the common precursors into the sex steroid pathway. For the morphology, in congenital adrenal hyperplasia, the adrenals are hyperplastic bilaterally. The adrenal cortex is thickened and nodular, and on cut section, the cortex appears brown as a result of depletion of lipid. The proliferating cells are eosinophilic cells intermixed with lipid-laden clear cells. The clinical manifestations of congenital adrenal hyperplasia include abnormalities related to androgen excess, with or without aldosterone and glucocorticoids deficiency. Depending on the nature and severity of the enzymatic defect, the onset of clinical symptoms may occur in the perinatal period, later childhood, or less commonly adulthood. In 21-hydroxylase deficiency, excessive androgenic activity causes signs of masculinization in females, including clitoral hypertrophy and pseudohermaphroditism in infants. Moreover, oligomenorrhea, hirsutism, and acne would occur in post-pubertal girls. In males, androgen excess is associated with enlargement of the external genitalia and other evidence of precocious puberty in young patients. Most men with congenital adrenal hyperplasia are fertile, but some have failure of Leydig cell development and oligospermia. In approximately one-third of individuals, the enzymatic defect is severe enough to produce aldosterone deficiency, with resultant sodium wasting and hypotension. It is worth to know that the treatment of congenital adrenal hyperplasia is with exogenous glucocorticoids, which, in addition to providing adequate levels of glucocorticoids, also suppress ACTH levels. Mineralocorticoid supplementation is required in the salt-wasting variants of congenital adrenal hyperplasia. The next topic is the adrenal insufficiency. It may be caused by either primary adrenal disease, primary hypoadrenalism, or decreased stimulation of the adrenals results from ACTH deficiency, and this is the secondary hypoadrenalism. For the primary adrenocortical insufficiency, it may be acute, called adrenal crisis, or chronic, termed the Addison disease. For acute adrenocortical insufficiency, it is worth to know that the individuals with chronic adrenocortical insufficiency may develop an acute crisis after any stress. In addition, rapid withdrawal of steroids or failure to increase steroid doses in response to an acute stress may precipitate a similar adrenal crisis because of the inability of the atrophic adrenals to produce glucocorticoid hormones. Moreover, massive adrenal hemorrhage may destroy the adrenal cortex to cause acute adrenocortical insufficiency. It occurs in patients maintained on anticoagulant therapy, postoperative patients with DIC, as well as during pregnancy and in patients suffering from overwhelming sepsis associated with Neisseria meningitis. This is called the Waterhouse-Friderichsen syndrome. This picture is for the Waterhouse-Friderichsen syndrome, which is a case of bilateral adrenal hemorrhage in an infant with overwhelming sepsis, resulting in acute adrenal insufficiency. In this microscopic field, little residual cortical architecture is discernible. The chronic adrenocortical insufficiency is called Addison disease. It is an uncommon disorder resulting from progressive destruction of the adrenal cortex. More than 90% of all cases are attributed to one of four disorders, and these are autoimmune adrenalitis, tuberculosis, and AIDS, as well as metastatic cancer. This table is to discuss the main causes of chronic adrenal insufficiency, and these are autoimmune adrenalitis, tuberculosis, AIDS, and metastatic neoplasms. For the autoimmune adrenalitis, it accounts for 60 to 70% of cases and is by far the most common cause of primary adrenal insufficiency in countries where infectious causes are uncommon. It occurs in association with several distinct autoimmune polyendocrine syndromes and caused by mutations in the autoimmune regulator AIRE gene on chromosome 21. Individuals with the autoimmune polyendocrine syndromes 1 develop autoantibodies against interleukin 17 and interleukin 22, which are the principal effector cytokines secreted by T helper 17 T cells. Because these two cytokines are crucial for defense against fungal infections, affected patients develop chronic mucocutaneous candidiasis. Infections such as tuberculosis may cause primary chronic adrenocortical insufficiency and account for as many as 90% of cases for Addison disease, but has become less common with improved anti-tuberculosis therapy. Tuberculous adrenalitis usually is associated with active infection in other sites, particularly the lungs and genitourinary tract. Patients with AIDS are at risk for the development of adrenal insufficiency from several other infectious agents, including the cytomegalovirus, Mycobacterium avium intracellular, as well as non-infectious causes such as the Kaposi sarcoma, which is the complications of the disease. The other cause is the metastatic neoplasms involving the adrenals. They are another potential cause of adrenal insufficiency. Carcinomas of the lung and the breast are the source of a majority of metastases in adrenals. In regard of secondary adrenocortical insufficiency, any disorder of the hypothalamus and pituitary that reduces the output of ACTH may occur alone, but in some instances it is only one part of panhypopituitarism associated with multiple pituitary hormone deficiencies. Morphologically, primary autoimmune adrenalitis is characterized by irregularly shrunken glands. On histologic examination, the cortex contains only scattered residual cortical cells in a collapsed network of connective tissue with a variable lymphoid infiltrate in the cortex and may extend into medulla. The medulla is usually preserved. In tuberculosis, the adrenal architecture may be affected by a granulomatous inflammatory reaction identical to that encountered in other sites of infection. When hypoadrenalism is caused by metastatic carcinoma, the adrenals are enlarged and their normal architecture is obscured by the infiltrating neoplasm. This table is for the clinical features of adrenal insufficiency. In general, clinical manifestations of adrenocortical insufficiency do not appear until at least 90% of the adrenal cortex has been compromised. The initial manifestations often include progressive weakness and easy fatigability. GI disturbances are common, include anorexia, nausea, vomiting, weight loss, and diarrhea. In patients with primary adrenal disease, increased level of ACTH precursor hormone stimulate melanocytes with resultant hyperpigmentation of the skin and mucosal surfaces, mainly the face, axilla, nipples, areolae, and perineal area. By contrast, hyperpigmentation is not seen in secondary adrenocortical insufficiency. Decreased mineralocorticoid, the aldosterone activity in patients with primary adrenal insufficiency results in potassium retention and sodium loss, with consequent hyperkalemia, hyponatremia, volume depletion, and hypotension, whereas secondary hypoadrenalism is characterized by deficient cortisol and androgen output, but normal or near normal aldosterone synthesis. Stresses such as infections, trauma, or surgical procedures may precipitate an acute adrenal crisis manifested by intractable vomiting, abdominal pain, hypotension, coma, and vascular collapse. Death follows rapidly unless corticosteroids are replaced immediately. After the demonstration of the adrenal cortex and its main clinical disorders, now I will try to discuss the neoplasm of the adrenal medulla. The most important diseases of the adrenal medulla are neoplasms, which include either neuronal neoplasms or pheochromocytomas. For the neuronal neoplasms, it includes neuroblastomas and more mature ganglion cell tumors, whereas the pheochromocytomas are neoplasms composed of chromaffin cells. So, the first discussion is about the pheochromocytomas. Pheochromocytomas are neoplasms composed of chromaffin cells synthesize and release catecholamines, and in some cases other peptide hormones. These tumors are of special importance because, although uncommon, they give rise to a surgically correctable form of hypertension. It is worth to know that pheochromocytomas usually subscribe to a convenient rule of tens. As you can see in this figure, 10% are extraadrenal, bilateral, malignant, and not associated with hypertension. So don't forget rule of tens. According to rule of tens, it is important to know that 10% of pheochromocytomas are extraadrenal, where they are called paragangliomas. 10% of the adrenal pheochromocytomas are bilateral. This proportion may rise to 50% in cases that are associated with familial syndromes. In addition, 10% are malignant, and other 10% of adrenal pheochromocytomas are not associated with hypertension. Of the 90% that present with hypertension, approximately two-thirds have paroxysmal episodes associated with sudden rise in blood pressure and palpitations, which can be fatal. It is now recognized that as many as 25% of individuals with pheochromocytomas and paragangliomas harbor a germline mutation in one of at least 6 known genes, including RAT, which causes type 2 men syndromes, NF1, which causes type 1 neurofibromatosis, others called the VHL, which causes von Hippel-Lindau disease, and there are 3 genes encoding subunits within the succinate dehydrogenase complex. These are the SDHB, SDHC, and SDHD, which is involved in mitochondrial electron transport and oxygen sensing. Morphologically, pheochromocytomas range in size from small to large hemorrhagic masses. On cut surface, smaller pheochromocytomas are yellow-tan, well-defined lesions that compresses the adjacent adrenal glands, whereas the larger lesions tend to be hemorrhagic, necrotic, and cystic, and typically efface the adrenal gland. Here is the gross appearance of pheochromocytoma, at which the tumor is enclosed within an attenuated cortex and demonstrates areas of hemorrhage. You could notice the coma-shaped residual adrenal glands at the lower portion. Microscopically, they are composed of polygonal to spindle-shaped chromatin cells and their supporting cells, compartmentalized into small nests by a rich vascular network. The cytoplasm of neoplastic cells often has a finely granules containing catecholamines. In addition, the nuclei are often pleomorphic. The microscopic appearance of pheochromocytoma is shown here, and it demonstrates the characteristic nests of cells, zilbolin, with abundant cytoplasm. It is not uncommon to find bizarre cells such as the one in the center of this image. Definitive diagnosis of malignancy in pheochromocytoma is based on presence of metastases. They may involve regional lymph nodes as well as more distant sites, including liver, lung, and bone. For the clinical manifestations of pheochromocytoma, hypertension is observed in 90% of patients. Approximately two-thirds of patients with hypertension demonstrate paroxysmal episodes associated with tachycardia, palpitations, headache, sweating, tremor, and a sense of apprehension. These episodes may also be associated with pain in the abdomen or chest, as well as nausea and vomiting. It is important to know that isolated paroxysmal episodes of hypertension occur in fewer than half of patients. The elevations of blood pressure are induced by the sudden release of catecholamines that may precipitate congestive heart failure, pulmonary edema, myocardial infarction, ventricular fibrillation, and CVA. In some cases, pheochromocytomas secrete other hormones, for example ACTH and somatostatin. The laboratory diagnosis is based on demonstration of increased urinary excretion of free catecholamines and their metabolites, namely vinyl-mandelic acid and metanephrines. Moreover, isolated benign pheochromocytomas are treated with surgical excision. With multifocal lesions, long-term medical treatment for hypertension may be required. The other neoplasm needs to be mentioned is called the neuroblastoma. It is the most common extracranial solid tumor of childhood during the first 5 years of life. Neuroblastomas may occur anywhere in the sympathetic nervous system and occasionally within the brain, but most common in the abdomen, mainly in adrenal medulla or retroperitoneal sympathetic ganglia. Most neuroblastomas are sporadic, although familial cases also have been described. The final subject that I will discuss is multiple endocrine neoplasia syndromes. Multiple endocrine neoplasia syndromes are a group of inherited diseases caused by proliferative lesions, including hyperplasias, adenomas, and carcinomas of multiple endocrine organs. The arising endocrine tumors have certain distinctive features that are not shared with their sporadic counterparts, and these are: first, the tumors occur at a younger age than that typical for sporadic cancers. Secondly, they arise in multiple endocrine organs, either synchronously at the same time or metachronously, which means at different times. Even in one organ, the tumors often are multifocal. The other distinctive features that we need to know is that these tumors are usually more aggressive and recur in a higher proportion of cases than similar endocrine tumors that occur sporadically. The multiple endocrine neoplasia has two types, either type 1 or type 2. Now I will discuss the multiple endocrine neoplasia type 1. It is caused by germline mutations in the MEN1 tumor suppressor gene, which encodes a protein called menin. Organs most commonly involved are the parathyroid, pancreas, and the pituitary gland. This is the 3 P's letters. This table illustrates the organs most commonly involved in multiple endocrine neoplasia type 1, and these are the 3 P's: parathyroid, pancreas, as well as pituitary glands. For the parathyroid, primary hyperparathyroidism accounts for 80 to 95% of patients. The parathyroid abnormalities include hyperplasia and adenomas. The second P is pancreas. Endocrine tumors of the pancreas are aggressive and present with the metastatic disease. They are functional, thus means secrete hormones. Zollinger-Ellison syndrome associated with gastrinomas and hypoglycemia associated with insulinomas are common endocrine manifestations. They are leading cause of death in MEN1. The last P is pituitary. The most frequent pituitary tumor with MEN1 syndrome is a prolactin-secreting macroadenoma. In some cases, acromegaly develops in association with somatotropin-secreting tumors. Next is multiple endocrine neoplasia type 2. It comprises two distinct groups of disorders that have unified by activating that mean gain of function mutations of the RET proto-oncogene at long arm of chromosome 10, region 1, band 1, subband 2. Multiple endocrine neoplasia type 2 is inherited in an autosomal dominant pattern. The multiple endocrine neoplasia type 2A is either MEN2A or MEN2B. For the multiple endocrine neoplasia type 2A, the organs commonly involved include the following. First, the thyroid, at which medullary carcinoma of the thyroid develops in almost all untreated cases, and the tumors usually occur in the first 2 decades of life. The tumors commonly are multifocal. The adrenal medulla could be affected, at which adrenal pheochromocytoma develops in 50% of the patients. Fortunately, no more than 10% of these tumors are malignant. And finally, the parathyroid. About 10 to 20% of patients develop parathyroid gland hyperplasia with manifestations of primary hyperparathyroidism. In regard of multiple endocrine neoplasia type 2B, patients develop medullary thyroid carcinomas, which are usually multifocal and more aggressive than in multiple endocrine neoplasia type 2A, as well as the pheochromocytoma could develop. It is worth to know that the multiple endocrine neoplasia type 2B has the following distinctive features. First, primary hyperparathyroidism does not develop in patients with multiple endocrine neoplasia type 2B. Secondly is that the extraendocrine manifestations are characteristic in patients with multiple endocrine neoplasia type 2B. These include ganglioneuromas of mucosal sites, mainly gastrointestinal tract, lips, and tongue. The other is the marfanoid habitus, in which overly long bones of the axial skeleton give an appearance resembling that in Marfan syndrome. Nowadays, routine genetic testing identifies RET mutation carriers earlier and more reliably in MEN2 kindreds. All individuals carrying germline RET mutations are advised to have prophylactic thyroidectomy to prevent the inevitable development of medullary carcinomas. This is a suggested reading for the adrenal insufficiency, and hopefully you will find it useful for you. Thank you.